Good morning, everyone. Myself, Pallavi Singh, SRN Department of Palliative Medicine, DMH Mumbai. Currently, I am doing my SRship on rotation at Mahavana, M- MPMMCC Varanasi Hospital, branch of Tata Memorial Hospital. Today's topic is severe acute brain injury. I'm very glad this topic was given me and this opportunity to present over here on this a big large platform. Next slide. So, acquired brain injury. Sorry. Acquired brain injury, it is a major source of health loss and disability worldwide. Globally, the annual incidence of traumatic brain injury is variably estimated at 27 to 69 million, but many survivors live with significant disabilities resulting in major socioeconomic burden. The classification is broadly classified into traumatic, non-traumatic brain injury, or it can be on the severity like mild, moderate, or severe brain injury, or on the basis of injury like diffuse or penetrating injury. So, the two types of acquired brain injury, we have the traumatic brain injury and the non-traumatic. Traumatic is like it is an alteration in the brain function or other evidence of the brain pathology caused by some external force to it. So patient with the TBI, that is a traumatic brain injury, suffer a wide variety of symptoms and lifelong disabilities, with approximately 43% of hospitalized traumatic brain injury patients develop long-term disabilities. Despite the recent decrease in the mortality rate because of the advancement in the medical care, still the disability rate of the TBI have not changed. So it is a concern. In a non-traumatic brain injury, it causes a damage to the brain by some internal factors such as lack of oxygen or the exposure to any toxin, pressure from a tumor, etc. can be the causes for the non-traumatic brain injury. So these are the different kinds of types of traumatic brain injury causes, like a trauma due to fall or any assault or a motor vehicle accident, sport, or the abusive head trauma, or gunshot wound, or a workplace injuries. While child abuse can also be one of the causes, domestic violence and blast injury, like in military actions. The causes of the non-traumatic brain injuries are stroke, hemorrhages, blood clot can be one of the cause, infectious disease, meningitis, encephalitis, seizures, electric shock, tumors, metabolic disorders, neurotoxic poisoning, like carbon monoxide or any lead exposure or any other thing like that, lack of oxygen due to the drowning or drawing down in choking, hypoxic or any anoxic injury, or drug overdose like opioids can cause the non-traumatic brain injury. External force that may result in the TBI are the like head being struck by any object or the head striking an object, or there is any acceleration, deceleration of the brain without the direct external impact, or a foreign body penetrating the brain, the force from a blast explosion, or other forces yet to be defined. The global trend, the global burden of the disease study published the following estimates regarding the traumatic brain injury. This was in 2016 data, where the annual incidence was estimated at 27.08 million with an age standardized incidence rate of 369 per 100,000 population. And the global TBI prevalence was estimated at 55.5 million with an age standardized prevalence rate of 759 per 100,000 populations. TBI were estimated to result in 8.1 million years of living with disability worldwide in 2016. Falls, like 35% were the single most common cause for the TBI in every socio-demographic index category. And the road traffic injuries, that is 17%, were the second most common cause. The reduction of TBI in a high SDI countries is thought to be a result of road safety regulations. The total burden of TBI was found to be 3 times greater in the low to middle income countries compared with the high income countries. So this is a case where Mr. A found a 28-year-old person without a helmet with a male prone and unconscious after he had lost the control of his motorcycle bike and went off the road. He was brought to the emergency department via an ambulance, and the incident occurred few hours back. This is a scan showing left. You can see the scan and can diagnose. It is showing a left acute SDH. The clinical severity score by which the traumatic brain injury has been traditionally classified using the injury severity score. The most commonly used is the Glasgow Coma Scale, which we all are aware of it, mild, moderate, severe, GCS, having in mild 13 to 15, loss of consciousness less than 20 minute per less than 20 minute to 1 hour, and PTA less than 24 hour. In moderate, it's 9 to 12, and LOC is 1 to 24 hour, and PTA is more than 24 hours or less than 7 days. In severe, where the GCS is very poor, 3 to 8, loss of consciousness is more than 24, and PTA is more than 7 days. I'm not going to read the Glasgow Coma, as we all are very much aware of this in our daily basis. But yes, the 3 components we look is eye-opening responses, which have the score like 4, 3, 2, 1 in verbal. There's verbal responses 5, 4, 3, 2, 1, and best motor response from 6 to 1. And this is the total score which we have seen over there. This is the second level for the assessment of the injury, is known as a head injury severity scale. His TBI can lead to several pathological injuries also, most of which can be identified on the neuroimaging, like skull fracture, like epidural hematoma or subdural or subarachnoid hemorrhage, intraparenchymal hemorrhage, cerebral contusion, or any intraventricular hemorrhage, or focal and diffuse patterns of axonal injuries with cerebral edema. In this image, we are seeing the EDH, that is the epidural hematoma. Neuroimaging scaling, on the city basis grading scales are the Marshall scale and the Rotterdam scale. So I have here listed this Marshall scale, which is widely used, and it has been shown to predict the risk of increased intracranial pressure and outcome in adult accurately. So the categories are like diffuse injury 1, axonal injury 1, no visible intracranial pathology seen on CT scan, diffuse injury 2, where the cisterns are present with midline shift of 0 to 5 mmVc, and diffuse injury 2, where swelling is present along with the above and the midline shift. The cisterns are compressed and they're absent with midline shift. And there's no high or mixed density lesions. Diffuse injury 4, midline shift is more than 5 mm, and evacuated mass lesion 5, any lesion surgically evacuated. Non-evacuated mass lesion 6, high or mixed density lesion more than 25 mm centimeters per cube, not surgically evacuated. So this is the primary brain injury, inflammation, primary brain injury with injuries occur, and there is a trauma hemorrhage. We can see them which is in men and 10 days. Secondary brain injury with inadequate cerebral blood flow is there. There can be brain tissue hypoxemia, mitochondrial dysfunction, which result in the release of neurotoxic factors. And in month and year, this is a final brain injury, ongoing process causing seizures, axonal injuries, progressive brain atrophy, manifest symptom due to the neural and the glial death. There can be paraplegia, long stay in the hospital, and then the patient is recovered as shown over here. But there are other cases that patient are not recovered also. Pathophysiology of the primary brain injury, it occurred at the time of trauma, direct impact. As we see, rapid acceleration, deceleration, or penetrating injuries at blast wave, external mechanical forces transferred to the intracranial content. Then the pathoanatomic sequel of primary TBI include the intra and extraparenchymal hemorrhages and diffuse axonal injuries. Extra-axial hematomas are generally encountered when the forces are distributed to the cranial vault and the most superficial cerebral layer. These include epidural, subdural, and the subarachnoid hemorrhages. This is the system mechanism of traumatic brain injuries. Is a systemic insult, result in hypoxemia, ischemia, diffuse axonal injury, contusion, hematoma, result in swelling, increase in intracranial pressure, and decrease in the CPP, which result in hypoxia. In the secondary brain injury, secondary TBI result from the cascade of molecular injuries of the mechanism which are initiated at the time of initial trauma and continue for hours or days. It is exacerbated by the modifiable systemic events such as decreased cerebral perfusion pressure, hypoxia, fever, and seizures. Neurotransmitter mediated excitotoxicity causing glutamate free radical injury to the cell membrane, electrolyte imbalance, mitochondrial dysfunction, inflammatory responses, apoptosis, and the secondary ischemia from vasospasm, focal microvascular occlusion, vascular injury. Approximately 1/3 of the patient with the severe TBI developed a coagulopathy, which will result or associated with increased risk of hemorrhage, enlargement, poor neurological outcome, and death. Injury, then there's a release of this marker, capsaicin, calpin, cytokines, cytochrome C, decrease in calcium homeostasis, increased microglia activation, mitochondrial stress, necrosis, apoptosis, which result in increased oxidative stress, lipid peroxidation, ROS production, APP, intracellular amyloid beta cytokines, and IGF-1 resistance. Increased result in hyperphosphorylation of the tau cytokines, oxidative stress, decrease in steroid biosynthesis, and calcium homeostasis, and this again this. Diffuse axonal, the different type of axonal traumatic brain injury. One of them is the diffuse axonal injury. A diffuse axonal injury can be caused by shaking or strong rotation of the head, as with a shaken baby syndrome, or by a rotational forces such with a car accident where the jerk is occur. And you can see in the CT scan, diffuse axonal injury. Next, contusion or seen in the mild and severe traumatic brain injury, both can be caused by the direct blow to the head, seen in gunshot wound, violent shaking of the head, or force from the whiplash types of injury. It can be both closed and open head injury. Contusion, it is a bruises, bleeding on the brain caused by the force to the head. And this can be result of the direct impact to the head. Large contusions maybe need to be surgically removed. These are the penetrating injury to the brain occur from the impact of a bullet, knife, or any sharp object that forces hair, skin, bone, and fragments from the object into the brain. It is a through and through injury occur when an object enters the skull, goes through the brain, and exits the skull. It includes penetration injuries like shearing, stretching, and rupture of the brain tissues. And abusive head trauma, that is a shaken baby syndrome. It's an abusive head injury occur when the perpetrator aggressively shake a baby or young child. The forceful whiplash-like motion causes the brain to be injured. Blood vessel between the brain and the skull rupture and bleed, causes the brain tissue to compress, while the injury causes the brain to swell. This damaged the brain cells. There's an abusive head trauma resulting in the abusive head trauma, which causes seizures, lifelong disability, coma, and death. There's an irritability, change in eating patterns seen in the such patient, tiredness, difficulty in breathing, dilated pupils, seizures, and vomiting are the signs of abusive head trauma. The baby experience such symptom and need immediate emergency medical attention. Mhm. Lock-in syndrome. It is a rare neurological condition in which patient is paraplegic. Paraplegic vertical eye movement and eye blinking can be used to communicate with others and operate environmental control. So we see the sign and symptoms of the traumatic brain injury. Mild traumatic brain injury, loss of consciousness for a few seconds to few minutes, memory or concentration problem can occur, headache, there can be a dizziness or loss of balance, nausea or vomiting, difficulty in sleeping. In moderate to severe brain injury, we see there's a loss of consciousness from several minutes to hours, slurred speech, inability to awaken from sleep, weakness or numbness in fingers and toes. There can be a loss of coordination. There can be a persistent headache or headache that worsens. We will see on the, so there's the classified as mild brain injury, moderate brain injury, and severe brain injury. I am only discussing the severe brain injury. So the patient can be unconscious exceeding 24 hours, can be in coma, there can be no sleep, wake cycle during loss of consciousness. There can be signs of injury appears on the neuroimaging test. These will help us to assess the severe brain injury. So in management, we have to see the clinical concern are the hypoxia or hyperventilation can occur to patient. There can be hypotension or hypertension, anemia, seizures can occur. There can be infection, hyperthermia, and spinal stability. So each of them is checked step by step, and the investigations are done. Like if a patient present in emergency ER with GCS score of less than 9, pre-hospital care is done, and then prevention of hypoxia is first seen, and hypertension. Then if patient is in ER, endotracheal intubation can be done if required, or frequent clinical neurological assessment and complicate and CT scan of the head is requested. Impending cerebral herniation is assessed and suspected in a patient with significant pupillary asymmetry can be assessed. Unilateral or bilateral fixed dilated pupil, decorticate or decerebrate posturing, or respiratory depression. All of them are suspected. And due to the elevated intracranial pressure, a patient with severe TBI, empiric intervention is recommended. Head of bed is elevated and hyperventilation is done. For such patient, we also recommend bolus doses of mannitol. Neurosurgery reference or done, or the surgeon reference, surgical evacuation of if there is any epidural, subdural, or intracerebral cerebral hematoma should be decided based on the volume or the associated mass effect in in conjunction with the patient's neurological status. For patient with severe traumatic brain injury and abnormal CT scan showing evidence of mass effect from lesions such as hematoma, contusion, or swelling, ventriculostomy, or any, and intracranial pressure monitoring is done along with the along with treatment of elevated intracranial pressure. Should be targeted below 22 mmHg. As I mentioned, appropriate first question include removal of the cerebrospinal fluid through the ventriculostomy, head of bed elevation, and appropriate analgesia and sedation, followed by osmotic therapy with either hypertonic saline or mannitol. Patient with elevated intracranial pressure refractory to the initial therapy. Treatment option include decompressive craniotomy. Patient with refractory ACP elevation have a generally poor prognosis, and further intervention should be based on a risk-benefit discussion with family. Anti-seizures medication should be given. If it is a short-term 1-week use of anti-seizure medication for prevention of early seizures. Patient with seizure should be treated to prevent reoccurrence. Antiepileptics for prevention or anti-seizures medication like phosphonidine can be given parentally. Things which also we should be looked: fever and hyperglycemia should be avoided for their potential to exacerbate secondary neurological injury. Nutrition support to calorie control should be achieved by day 5 from injury using internal nutrition. Coagulopathy should be corrected to maintain an INR of less than 1.4 and platelet count of more than 75,000. Mechanical thromboprophylaxis with intermittent pneumatic compression for the prevention of VTE. Antithrombotic agent is individualized based upon the assessment of competing risk of venous thrombosis and intracranial hemorrhage expansions. So the complication which we see, like vegetative state where the individual is unaware but being to have sleep and wake cycle, normal digestion, breathing, and heart rate, may open his eyes or his or her eyes. The individual may occasionally respond to stimuli, and then there is a persistent vegetative state. The treating physician consider a person to be in a persistent vegetative state 1 year after traumatic brain injury or 3 to 6 months in the non-traumatic brain injury, like in hypoxic or anoxic brain injury. There's one other complication which is seen in the traumatic brain injury. It is a paroxysmal sympathetic hyperactivity. There's a disconnection of from the inhibitory center damaged by the brain injury and leaves an intact sympathetic drive to be hyperactive. Head injury, long-term management, complication, and outcome. Timing of tracheostomy should be assessed. Early tracheostomy reduce the number of days of mechanical ventilation, but does not affect the mortality or incidence of pneumonia. Timing of extubation, early extubation for patient meeting extubation criteria does not increase the risk of pneumonia. Skin care should be seen, changing patient position every 2 hours, and use of air mattresses should be encouraged. Nutrition, initial IV fluid, and then the nasogastric tube feeding or PEG. Bladder care is encouraged to the caregiver. Condom catheter for male patients, indwelling catheter may be necessary. Clamping the catheter and release of every 3 to 4 hours to maintain the bladder tone. Bowel care, enema for fecal impaction, stool softener, suppositories, and anal stimulation. Eye care should be done. Eye should be covered. Avoid corneal injury by using eye drop and ointment. Management of restlessness and agitation. avoid unnecessary sedation in case of excessive severity or damage of agitation. A short-acting benzodiazepine may be indicated. Oh, I cannot change the slide, just a second. Um, so rehabilitation is a very important part in the severe acute brain injury. Um, Prevalence of residual disability arising from brain injury, physical deficits such as altered muscle tone, impaired balance, impaired coordination. There can be impaired sensation, muscle weakness, and impaired motor control, impact on activity and in the patients, gait, balance, and mobility. The treadmill training or gait use can be done. Orthosis and gait orthosis may be of the shelf or custom made to improve the ankle foot alignment and other physical impairment that have a negative impact on gait ability. Task specific and repetitive task training is encouraged. By repetitive task oriented activities are recommended for improving the functional ability such as sit or stand or fine motor control. Virtual reality training is encouraged, is a new thing. It's an emerging area in the rehabilitation enhanced by the development and popularity of commercially available interactive computer gaming devices, physical fitness training, walking aid, etc. Um, for the spasticity and muscle tone, incidence rate is seen in the 75% of the people with a severe traumatic brain injury. Splint cast stretches orthosis are used. Cast, splint, and passive stretching may be considered in cases where the contracture and the deformity are progressive. Oral anti-spasticity medication can be used like baclofen, tizanidine for the spasticity treatment, and the botulinum neurotoxin is also one of the things which is used in the spasticity in a long-term care vegetative state patient. Cognitive rehabilitations, comprehensive holistic treatment program, like in post of acute setting, interventions for cognitive deficit should be applied in context of the comprehensive holistic neuropsychological rehabilitation program. Interdisciplinary team using a goal-focused program which has the capacity to address the cognitive, emotional, and behavioral difficulties with the aim of improving functioning in the meaningful everyday activities. The other most pharmacological intervention during the rehabilitation address symptom for epilepsy, depression, agitation, sleep, cognition, and or motor function. So for the long-term discharge planning in the traumatic brain injury or the other brain injury rehabilitation, for the acute and the subacute, they are classified. Like in acute, we have to assess the emergency evaluation, then emergency department, intensive care unit, and specialty, the neurotrauma and multi-trauma, which can lead to the long-term acute care where the rehabilitation and the dependent living supported living program, group home supported living program are encouraged, and the caregiver nursing support are um, arranged. So there are some other kind of non-traumatic brain injury like acute toxic metabolic encephalopathy in adults. It is a non-traumatic acquired brain injury or something that happened to the brain after the birth. That TME is a debilitating, especially as we age and causes changes in the physical and the cognitive functioning. The causes of toxic metabolic encephalopathy are numerous and varied. Some causes are infection, dehydration, malnutrition, alcohol toxicity, and the other causes of the non-traumatic brain injuries. Um, So there was a Mrs. XY, 28-year married female, no case of carcinoma of breast, presented in emergency with complaint of left side weakness, loss of consciousness, sudden onset. Patient had BP of 200 by 100 mmHg. So brain's imaging was suggested and lab investigation were done. ABC airway breathing care was taken care of, and neurologist and neurosurgeon reference were given. This case can be a cause of stroke, can the stroke is also one of the major non-traumatic brain injury. There's a high rate of morbidity and mortality after stroke emphasizes the importance of clinician to integrate palliative care into the both acute and the post-acute system of stroke care, specialist stroke palliative care, identification of basic management of pain and other physical symptoms, as well as the psychological suffering, serious illness communication, for example, asking a patient about their values and the treatment goals and effectively discussing a likely prognosis. Care coordination, such as transition out of the hospital, should be looked out, especially when the time of limited trials is involved. So there's a trajectory, neurological illness trajectory. We all know the first one, which can be seen in the cancer, short period of decline. Then there's a chronic illness exacerbation, which is seen in the multiple sclerosis or in a heart failure patient. And then there is a prolonged trajectory, which is seen in the dementia, Parkinson's disease. And this is the third last one, which is seen in the severe acute brain injury, like stroke or any traumatic brain injury. Here, with the trajectory can lead to the death or the persistent vegetative state or improvement with disability. So a patient with persistent vegetative state require long-term care and will have a significant impact on the families and the caregiver, producing a substantial emotional, behavior, and the relationship difficulties count. And if the patient is improved with the disability, in the severe acute brain injury has a major economic implications owing to the hospital care and the rehabilitation costs. Overall prognosis, which is assessed by the usually by the Glasgow scale, mild, as we have seen, temporary or permanent neurological symptoms, moderate disability, loss of consciousness greater than 30 minutes. There can be physical or cognitive impairment, which may or may not resolve, benefit from rehabilitation. There can be a severe disability like coma, unconscious state, and there will be no meaningful response, no voluntary activities. There can be a vegetative state, the scoring is less than 3, sleep-wake cycle, no localized response to pain, persistent vegetative state, which lasts longer than 1 month, and then there's a brain death, no brain function. Specific criteria needed for making this diagnosis. There are several papers which have studied that integration of palliative care into the care of neurocritically ill patient have resulted in a good care. This paper was by the Frontera et al. Here, they said that the application of palliative care principle concerning symptom relief result in a good goal setting and family emotional support. provided by the clinician as a framework to address the decision making at time of crisis that enhances patient family autonomy and the clinician professionalism. Uh, this is a case. Meet Mrs. AZ, 67-year female, admitted under um, admitted under my care, suggested early limitation of care on initial consultation. First neurosurgical consultation was done, agreed on poor prognosis. Then family asked for the second neuro consultation. Husband, I want her come back home, operated, decompressive craniectomy done 16 hours later after the admission, 16 hours after admission, discharged with tracheostomy, PEG. 2 weeks later, the MRS 5 decannulated 6 weeks later, and the PEG was removed at the 6 month. So, so the palliative care in the moderate to severe role of palliative care come in the moderate to severe traumatic brain injury. One of the most common acute neurological conditions seen in the neurocritical care ICU due to its high risk of death with mortality ranging from 12 to 61.2%. We provide a social support and establish a goal of care. So, what a care, palliative care physician do. Neuropalliative care skill set, which consists of effective communicate, prognosis, effectively communicate prognosis estimated from the literature, like communicate best case, worst case. For example, will never be normal again, less than 10% of chances of being able to stay alone at home, to do her own thing herself, manage the uncertainty, and master the common preferences, sensitive decisions, know major decision with each subspecialty, elicit preference accurately, listen more than talk. Hypervigilant shared decision making should be done. Detect and manage the whole body pain, physical symptoms, psychological symptoms, existential distress, social pain, and palliative options at the end of life should be given to these patients. So patient with severe acute brain injury and their family faces a very unique illness trajectory. There's a tragic choice in the setting of prognostic uncertainty is there. Shared decision making with unclear decision preferences are present. So in decision making capacity, impaired medical decision prevalent of severe acute brain injury and is strongly related to the injury severity. Appreciation occur in 10 to 30% of patients with mild brain injury, 50% of patients with moderate brain injury, 50 to 80% of patients with moderate to severe brain injury. And in a comatose state, surrogate decision makers assume the main decision making capacity. Decision making points should be seen in the severe acute brain injury. Initial 1 to 3 days neurosurgical intervention is done. In early 1 to 5 days, brain death determination can be assessed. Indeterminate, like 10 to 20 days, tracheostomy, PEG versus palliative extubation can be discussed. Late, that is more than 1 year, withdrawal of artificial nutrition and hydration. When does the chronic disorder of consciousness reach a stable state? In the traumatic brain injury, 3 to 12 months, and in the non-traumatic, it is 1 to 3 months. So, um, advanced care planning should be discussed versus living will. What is advanced care planning? Is a process that support adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care to help to ensure that they receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. Advanced directives and medical power of autonomy, surrogate and decision makers, spouse, adult, children. First, we will share decision making, how should be discussed with the patient. So there should be a clinical input from the physician side and the patient surrogate input. So we will, from the patient side, review the advanced plan document if there is any surrogate understanding of the patient values and systems, wishes, and personal preferences. Like if patient have ever mentioned, I don't want to be admitted in the hospital or intubated, that should be addressed by them. A clinician will assess by the prognostic scale using the GCS 4 score or Marshall head injury, and consider individual patient factors. The age is the most important, then the pre-morbid function and the cognitive state, any medical comorbidities if present, and how the patient was physiological status during admission, and the neurological status, which help them to come on decision. So the best prognostic estimate of the neurological outcome and quality of life. Best estimate of patient goals and value of acceptable quality of life will help setting a goal of care through shared decision making. It's the same thing. So in this illness trajectory, it has been strongly recommended that the withdrawal of life support should not be done prior to 72 hours. Also, the shared decision should not be discussed before 3 days. It should be discussed after that only. You can discussing the is brain death. Is brain death really death, chronic brain death, formal diagnosis of brain death with survival of more than 1 week, withdrawal or with or without the brain death determination, or organ donation is with 1 to 7 days. So there was a paper on brain death ethical challenge to palliative care concept for family care. Here, the patient was of road traffic accident, admitted in ICU, declared brain death, but the wife was not present. So the caregiver wanted the patient to keep him on the ventilator and let the wife come to take the decision. But since the patient was shifted on the ventilator, and when the caregiver feel that patient is not dead, so in this scenario, the clinician should weigh the risk and benefit of harm to the family when deciding the how long to keep the brain dead patient on ventilator. So the pronouncement of the death, which is good basic medical care regardless of the cause of the mechanism of the death, should not be delayed or for family consideration, because in this case the family don't want patient to put them off from the ventilator despite the palliative care physician involvement and repeated counseling. So there's a risk management should be involved early in the decision process if the life support is withdrawn without the family assent. So this is motor capacity versus cognitive capacity. This is a modified ranking scale of measuring with a degree of disability or dependence in the daily activities of people who experience a stroke. Then there's a good recovery, professional reinsertion is done. There's a moderate disability, they live independently, and then there's a severe disability. After that, the communication should be done. Open, honest communication should be done regarding the disease and the progression. Minimal confusion state, with a voluntary behavior occur, and the patient is in a vegetative state. The eye opening only is present, and patient goes into the coma. So, withdrawing life-sustaining therapy for the patient with severe traumatic brain injury, a paper by David H. et al. There's always a good communication with the family need to be begun early, occur frequently, and deliver a consistent message to achieve an optimal outcome, and timing of any withdrawal or support should be done. End of life care should also be planned by good communication, assessment of the care planning should be done. There should be a good symptom management, taking care of all the symptoms in the hospital and at the home, and then advanced care planning should be discussed. Usually in India, we don't do that. So there was a guidelines of end of life and palliative caring Indian Intensive Care Unit by the Archimony et al. Is a very famous paper, and there was a case of Arnold Schonbach case. She spent nearly 42 years in the vegetative state after a sexual assault. So this case came in public attention in March 2011. The Supreme Court of India delivered the judgment on plea for allowing euthanasia for a patient in a vegetative state for 37 years. The appeal was in the form of public interest litigation filed by a social activist. And thus, the Supreme Court discriminalized the withdrawal of care when the futility is recognized. The role of palliative care in adult moderate to severe traumatic brain injury. This is also one of the paper by the Hebetala et al. They have also mentioned that early intervention of the palliative care physician result in a good quality of life, a good decision making for the treatment plan, and the patient experience should be trigger physician to practice the palliative care principle when needed to consult specialist palliative care. So we learned today the severe acute brain injury types, classification, pathophysiology, sign and symptoms, management by integrated plan, timely referral to the specialist palliative care, shared decision making. There should be honest, open communication. Doing right can never be illegal. Due process has to be followed, and documentation has to be completed. Thank you. Any questions?
Yes, thank you, Pallavi. Arun, are there any questions?
No questions.
Ooh?
No questions. No questions.
No questions.
No questions again. We can still wait for some time, but no questions today.
Okay, so Dr. Joyita, you want to add in this seminar, please?
I think she did a presentation was quite comprehensive, and she took it point by point. So I think questions we would have wanted to ask have been clarified, at least to me. Thank you, Pallavi, for it can be a complicated topic, but you took it very simply and a very clear and comprehensive presentation. Thank you very much, and thank you, Sushma ma'am.
So, I think I could have heard what Dr. Joyita has said, that it is not that a palliative care physician will start managing acute head injury, but a palliative care physician should know everything about head. acute head injury. What is mild, moderate, and severe? She has explained it so well. What are the symptoms, how they manage, and it is important that slowly the way we are developing all over India. Pallavi, can you stop sharing so that people
Yes, ma'am. Yes,
the
ma'am.
gallery?
Sure, ma'am.
The way we are developing all over India, slowly I can visualize that after 5 years there will be a dedicated neuro palliative care uh, branch, means like not branch but neuro palliative care physician all over all over hospitals. And it is important that our young palliative care physician, they should know everything about this topic also. And Pallavi has tried her level best, because it is ultimately a neurologist or neurosurgeon's topic. But she has tried her level best, and I am sure that she has covered most of the aspects of identifying that how a palliative care physician can have a palliative care approach when a patient with the acute head injury or acute brain injury comes to the hospital. So all the MDs and those whosoever wants to, who were listening this topic carefully, I think I just want to say that all these topics and today's slides especially are very, very important. And I'm telling you that if you will not know the subject, people will not listen you. It is important that all of us should know the subject first, and then only we should enter in the others branches. Till now we were working alone, and we were trying to integrate palliative care in oncology, but we have to go beyond oncology, and going beyond oncology, we have to go understand these topics very well. Because when we were doing MBBS, it's okay. When we were doing our own MD, you were learning palliative medicine concept, and when you realized that, oh, suddenly we are posted in neurology or neurosurgery, there are so many things which are unanswered, and these classes are very, very important. And I can tell you that if a resident who is going to give exam, if he or she will attend these classes very carefully, I think he will be able to answer so many important things in the exam, and he will be able to practice when they will go to the different branches. So Pallavi, thank you very much.
Thank
You
you,
have
ma'am.
covered almost all this topic very well, comprehensively. Arun, you are the senior most of all these residents. Do you have any comments?
No, I don't have any comments. Thank you, Pallavi. And
Yes, sir.
there are some congratulatory comments for Pallavi on the chapter as well.
So good, thank you very much. Don't forget that one evening we are going to meet in the next in the evening. One Monday we are going to meet in the evening. Which was the Monday? Archana, Nisha?
8th, ma'am. November 8th.
It is 8th. So there is one more class, and then on 8th of November, it's an important topic. And don't come at 6:30 in the morning. We will meet in the evening, because Dr. Fiona, and with Dr. Fiona, Dr. Santosh Chaturvedi will also join, and they will discuss what are the ethical dilemmas of palliative care. And I don't think that Dr. Fiona and Dr. Santosh better anyone can explain this topic. So please don't forget on 8th of November. So we will have one more class after this in the morning. Next Monday, we will see you next Monday, and have a happy week. Thank you very much, Pallavi. Thank you, Nisha, Archana, Dr. Joyita, and Arun. Thank you very much.